Welcome to this session of Women's Health, and in today's session we're going to be looking at Polycystic Ovarian Syndrome. So to basically understand this topic, we need to appreciate the anatomy, and when we're looking at the anatomy, we need to look at the at least the size of the ovaries. So approximately the ovaries are 3.5 centimeter in length, 2 centimeters in width, and 1 centimeter in thickness. They are covered by simple cuboidal germinal epithelium, and beneath they're just covered by a tunica albuginea, which is just a dense connective capsule. The internal divisions consist of a cortex, which is just a functional tissue with follicles in various stages. Okay, they also have a medulla, which is supplied with blood vessels, lymphatics, nerves, and also it contains an idiom. Okay, so to simply appreciate the anatomy, we need to look at a structure of the follicle, which has got the thicker cells, the granulosa cells, the antrum, follicular fluid, corona radiata, the zona pellucida, the oocyte itself, and also the ovarian cortex. So in this structure, I want us to particularly pay attention to the thicker cells and the granulosa cells. Okay, the thicker cells are the outermost layer cells, and the granulosa cells are the innermost layer cells. Now, why do we want to focus on these cells? It's because in polycystic ovarian syndrome, these are the main cells where luteinizing hormone and FSH works on. Okay, so improper stimulation of these two cells leads to overproduction or hormonal imbalance. Okay, so we're going to look at that as I explain more. So just to basically give you a background, what basically happens is that luteinizing hormone stimulates the thicker cells, okay, which are outside, and the thicker cells will produce a hormone called androstenedione. Okay, when that androstenedione is formed, it forms progesterone from with the help of cholesterol. Okay, so when androstenedione forms progesterone with the help of cholesterol, that androstenedione diffuses further into the granulosa cells. Okay, so when the androstenedione diffuses further into the granulosa cells, what happens is that with the help of aromatase enzyme, it is converted to the androstenedione is converted to estradiol, which is a potent form of estrogen, which we need in our menstrual cycle or in the body for us to have a proper hormone imbalance. Okay, so this system needs to be balanced, but you'll find that in PCOS it's very unimbalanced, and we're going to look at how that happens. Okay, because there's over production of luteinizing hormone, so there's overstimulation of the thicker cells. Okay, so I'm going to explain more as we go on, but with that background, it's going to help us as we move. Okay, so the follicles produce estrogen from the granulosa cells, and progesterone from the corpus luteum, and androgens from the thicker cells. Okay, the corpus luteum produces progesterone, and in the post ovulation, what happens is that corpus luteum degenerates to corpus albicans if there's no pregnancy. Okay, with that being said, we just want to talk about oogenesis and follicular development. So oogenesis just starts in fetal life. So the oogonia, which further develops to a primary oocyte, and there's arrest at prophase 1 until puberty. So at birth, there are about 700,000 oocytes, and by puberty, only 400,000 remain. Okay, so the pubertal hormones, FSH drives the primordial follicles to develop into the primary follicles, and then it goes to a secondary, and finally to a mature graphene follicle. Now you will find that in polycystic ovarian syndrome, there is a reduced amount of FSH. So there will be an arrest of these follicles, which will not reach to a maturation of the graphene follicle. Okay, because remember what I said is that luteinizing hormone is higher compared to FSH. Okay, so this ends up causing the follicles not to mature, and a person will often have what we call an ovulation. Okay, so the antrum marks the development of the secondary follicle. So the antrum is just the follicular fluid in a secondary follicle. Okay, so follicular development in the menstrual cycle, we have got the primordial follicle, we have got the developing follicle, we have got the mature follicle, and we have the ovarian, we have got ovulation taking place. So the antrum is just that fluid region there, okay, which marks development of a mature or secondary follicle, or the Graafian follicle itself. Okay, with that understanding, we need to look at ovulation. So ovulation happens when there's a luteinizing hormone surge, which triggers rupture of the mature follicle. Sorry. So when this happens, um, it's mostly triggered at day 14 of the 28 day cycle. But remember to say, um, in um, in polycystic ovarian syndrome disease, this mechanism is altered because you cannot have a surge or you cannot have a rupture without a mature follicle. Okay, so remember we said the stasis of growth for the follicle, so it does not even reach the mature follicle. So luteinizing hormone surge cannot take place because the follicle is not yet mature, and it cannot release that mature egg. Okay, so the secondary oocyte is released and is surrounded by a zona pellucida and coronal radiator. So in a normal, this is just the normal physiology. Okay, um, when fertilization takes place, it's there's completion of meiosis 2, and if there's no fertilization, the oocyte degenerates. Okay, so after ovulation, the corpus luteum supports the endometrium, and if the egg is not fertilized, it ends up happening to cause menstruation. Okay, because after ovulation, the corpus luteum degenerates to form a corpus albicans. Okay, so not to confuse you, but let's just look at the brief pathophysiology of polycystic ovarian syndrome. Okay, so before I even go into further into detail into this pathophysiology, I would like us to think of it as a two-way highway. Okay, as it happening in two folds. Okay, what I mean by that is, let's look at the first thing that we're going to talk about is the polycystic ovarian syndrome happens due to predisposition of other factors such as genetics, obesity, a sedentary lifestyle, intrauterine androgen exposure. Okay, so and also other comorbidities such as diabetes mellitus type 2, dyslipidemia, and also heart disease. Okay, so we're going to start with the first principle, which is that it's just going to be increased gonadotrophin releasing hormone. Okay, which is going to be released in a pulsatile form. Okay, so that increase in gonadotrophin releasing hormone is going to cause an imbalance of production of luteinizing hormone and FSH. So the luteinizing hormone will be in a higher ratio. Most of the time it's 2 to 1, and sometimes it's even 3 to 1. Okay, so with that being said, that luteinizing hormone goes and acts on the thicker cells and further produces ovarian androgens to be produced. Okay, so that will cause excess production of androgens in the system. Okay, so when the luteinizing hormones are being produced, they go uh, on the thicker cells, okay, and disrupt the production of progesterone, and furthermore cause high production of the ovarian androgens to be produced. Okay, so with that being said, what will happen when there's excess androgens in the body? Okay, it will lead to arrest in the antrum follicular development and further lead to what we call polycystic ovaries. Okay, now that was the one way path. Okay, well, let's look at the other way in which it can also happen. Okay, so these two things can happen at the same time. So sometimes due to comorbidities such as insulin resistance and heart disease and dyslipidemia, what happens is that there is insulin resistance build up. Okay, so which leads to hyperinsulinemia. Okay, sorry about that, hyperinsulinemia. Okay, so that hyperinsulinemia will cause buildup of androgens in the system. Okay, now how does hyperinsulinemia do that? Okay, so when there's too much insulin in the system, it reduces a hormone produced by the liver, which is a sex hormone binding globin, which is responsible for binding the free androgens in the system. Okay, in the body. So when that hormone is reduced, it also binds free testosterone. Okay, so when that hormone is reduced, you find there's excess testosterone and also excess free binding or excess androgens in the system, because that hyperinsulinemia has caused a reduction in the sex hormone binding globin. So just think of the sex hormone binding globin as the carrier of androgens and testosterone. But with it not being uh, um, in high concentration or it being reduced, there is an excess of androgens in the body. Okay, so that further leads to what we call now androgen excess, which also leads to an arrest in the antrum follicular development, and it leads to polycystic ovaries. Okay, in mature ovaries, which are just going to be uh, many in nature. That's what we mean when we say polycystic. There are many cystic ovaries which appear like string of pearls on the ultrasound. Okay, now remember to say if the ovaries are not mature enough, ovulation cannot take place. So this person won't have any ovulation taking place, and we call that an ovulation. Okay, so when this happens, the person will be predisposed to a decrease in progesterone release. Okay, because uh, they're not having that formation of the corpus luteum, and also hence there's decreased production of progesterone, and there's high amount of unopposed estrogen, which predisposes them to endometrial hyperplasia and further causing a risk of endometrial cancer. Okay, so that anovulation can cause also an ovulatory bleed. Okay, it can cause irregular cycles. Okay, so with that pathophysiology being understood, once you get the pathophysiology, it's easy to understand how we're going to be treating PCOS and the management. Okay, because now you understand that insulin resistance can also predispose someone to having hyperinsulinemia, which is going to further cause androgen excess because of reduced sex hormone binding globin, and also there's increased gonadotrophin releasing hormone, which is released in a pulsatile form, which is going to cause an imbalance of luteinizing hormone to FSH. So the luteinizing hormone will be more and will go and act on the thicker cells and will cause ovarian androgen hormone to be produced from the ovaries. Okay, so how does the body respond, or what do we do when a patient or how does a patient with excess androgens present? So they can present with hirsutism, just facial hair. They can present with acne. They can present with alopecia. Okay, and sometimes even present with depression. So what we do for these patients with hirsutism, we can also put them on oral contraceptive pills. Okay, we can put them on spironolactone just to um, improve on these symptoms. Okay, we can also put them on clomiphene citrate. Okay, for that anovulation, if we want to induce ovulation, we can put them on clomiphene citrate, because we know that we know to say that this patient is not having ovulation because they are immature follicles. So we can induce that ovulation using clomiphene citrate, and we can also put them on metformin for that insulin resistance. Okay, just to improve the insulin resistance. Okay, with that being said, let's move on and consolidate on other points as well. So the definition of polycystic ovarian syndrome is just multiple follicular cysts in the ovaries due to the hormonal imbalance which we've been talking about, luteinizing hormone, FSH. Okay, so the core hormonal disturbance is increased luteinizing hormone production, okay, which further leads to also decreased low FSH. Okay, so to come back to this point, what I would like to also mention is that in polycystic ovarian syndrome, there is also production of a hormone which we call estrogen. Okay, so remember to say there is insulin resistant, and most of these patients, what happens is that the androgens are taken deposited into the adipose tissue. Okay, when the androgens are deposited into the adipose tissue, there's a peripheral conversion of those androgens to estrogen. Okay, peripheral conversion of those androgens to estrogen, which is just a weaker form of estrogen, because remember, we need a stronger form of estrogen, which is normally produced in the ovaries. Okay, in the granulosa cells, we need that estradiol. Okay, now when we have that estrogen, it sends a negative feedback. Okay, so when it sends that negative feedback, the estrogen disturbs the hormonal imbalance. Okay, it contributes to the hormonal imbalance, furthermore leading to the production of more luteinizing hormone rather than also producing FSH. Okay, so that was is a very important point to note, that the estrogen is also produced in the adipose tissue. A weaker form of estrogen is produced in the adipose tissue in polycystic ovarian syndrome. The other thing we can talk about is the luteinizing hormone and FSH ratio, which is mostly 2 to 1, but sometimes it can even be um, 3 to 1. Okay, this is just a picture showing us polycystic ovarian syndrome. Okay, so it's just multiple small fluid filled cysts. Okay, as you can see in the diagram, due to hormonal imbalance. Okay, that's how a patient can come in. So just look at the consequences. There is elevated luteinizing hormone, which stimulates the thicker cells, and those thicker cells will lead to increased ovarian androgen production, as we've mentioned earlier on. So the another organ which already produces androgens in the body is the adrenal glands. So that also adds androgens which are already being produced in the body. Okay, due to this already existing hormonal imbalance. Okay, the androgen, the adrenal glands also adds to the androgens. Okay, so we have that causing hyperandrogenism and hyperandrogenemia. Okay, so the peripheral adipose tissue, as I mentioned on, converts androgens to estrogen. Okay, so that increased the circulating estrogen exerts a negative feedback on the pituitary gland and suppresses FSH. So it makes sense to say why we have that ratio of high luteinizing hormone and low FSH. Okay, so with that being said, the low FSH is inadequate in the granulosa conversion of androgens to estradiol. Okay, so as I mentioned earlier on in the beginning of the session, to say we need this estradiol to be produced from the granulosa cells, and the hormone which stimulates the granulosa cells is is FSH. So if there's no FSH, there's no conversion of androstenedione to to estradiol. Okay, so that's what happens, and that further leads to follicles are not to mature and they become cystic. Okay, so if you understand the first point, it's easy to pick up these points because we're just consolidating and bridging them from the points we've already talked about. Okay, so that remember the endostradiol seeps from the thicker cells into the granulosa cells, and with the effect of the aromatase enzyme, it is converted to estradiol. Now, in this situation, if the granulosa cells are not stimulated, there is the follicles do not mature. Okay, so they become cystic. That's why you see polycystic. There are many cystic ovaries which show like a string of pearls on ultrasound. Okay. Okay, just a table summarizing everything we've talked about. Okay, so with predisposition of genetic link, smoking, insulin resistance, even Cushing disease. Okay, the symptoms can be amenorrhea, oligomenorrhea, acne, an increased BMI, hirsutism, um, subfertility. Okay, because someone is not ovulating, so they cannot fertilization cannot take place. Insulin resistance, all these parameters. Okay, so you can just look at this and also just see and also make sense of what we have already talked about. Okay, so with that being said, there are key pathological findings we need to see on ultrasound for these patients. Okay, so the key pathological findings, you see ovarian enlargement greater than 10 centimeters cubic, and there are thickened ovarian capsules, and there's also increased trauma tissue, and also there are multiple scapular follicular cysts. Okay, and which are commonly greater than 11 cysts, each 2.9 millimeters. Okay, or 2 to 11 millimeters in diameter, and the ovaries are often pale and whitish. Okay, so just to put it into perspective, these appearances can also be found in a normal healthy individual. So we do not use the appearance of the cyst to quantify our diagnosis of polycystic ovarian syndrome. We need to have other clinical findings so that we consolidate and make an approved diagnosis. Okay, so with that being said, we have already talked about follicular stimulating hormone. Okay, promoting follicular maturation, which is not happening in polycystic ovarian disease. We've talked about luteinizing hormone, okay, which triggers ovulation and also stimulates the thicker cells to produce androgens. Okay, so the thicker cells and the ovarian cells producing androgens in response to FSH. We also talked about the granulosa cells. Okay, the granulosa cells. The follicular cells are converting the androgens to estradiol with that aromatase enzyme there under the stimulation of FSH. Okay, so so when you're making a diagnosis of polycystic ovarian disease, we need to exclude other pathologies such as um, the thyroid dysfunction, congenital adrenal hyperplasia, hyperprolactinemia, androgen secreting tumors, and also Cushing syndrome. Okay, so the diagnostic criteria for polycystic ovarian syndrome should be quantified, or we use a Rotterdam criteria, which consists we have to have at least two or three of these features. Okay, so the features include oligomenorrhea or amenorrhea, which are just menstrual dysfunctions. We have got clinical and biochemical hyperandrogenism, which is just hirsutism or elevated androgens. We should also see polycystic ovaries on ultrasound, which are greater than 8 to 12 subcapsular follicles and less than 10 millimeters, and there's also should be increased stroma volume. So we need at least two of these features to consolidate our diagnosis of polycystic ovarian syndrome. Okay, so with that being said, for patients with suspected polycystic ovarian disease, we need to take a detailed history of their menstrual cycle. Okay, we need to ask them if they're having irregular menstrual periods, how many pads they're changing, are they fully soaked. Okay, because they can be have irregular menstrual periods due to that anovulation we've been talking about. We need to ask them if they are how is their reproductive life. Okay, we need to ask him for their metabolic history as well. Okay, we need to order for hormonal profile. Okay, we need to order for luteinizing hormone, FSH, total testosterone. As I said, testosterone is increased because of the reduced sex hormone binding globin, which is produced by the liver, which is also responsible for binding the free testosterone. We also have a hormone which we call the DHEAS. Okay, that's just dehydro epiandrosterone sulfate. Okay, so we use this test just to investigate other sources of androgens, where they're coming from. Okay, we can also do a prolactin. We can also do a thyroid stimulating hormone. Okay, to rule out thyroid pathologies. We can also do metabolic labs, okay, such as glucose, insulin, and lipid profile. Remember, diabetes mellitus type 2 can predispose, and also patients with heart disease, because they have that dyslipidemia, okay, high cholesterol levels. Okay, so with that being said, some of the presentations that we are going to talk about, this just to recall, or just to consolidate on this information, we're going to remember to say in post-ovulation phase, we need the corpus luteum is degenerated into the corpus albicans. So the other presentations of people with PCOS is they have got acanthis nigricans, so it's just a velvet hyperpigmented skin, okay, from hyperinsulinemia, okay, so which is mostly found in the neck and in the armpit region. Okay, we have got hyperandrogenemia, which is just elevated androgens causing hirsutism and acne, so facial hair there, a lot of facial hair. We've got estrogen. So estrogen is just a weak form of estrogen, okay, which is from the peripheral adipose tissue, okay, conversion of androgens in the adipose tissue. Okay, so with that being said, we can now talk about the clinical features. So the clinical features, as I've said, is just menstrual irregularities such as oligomenorrhea, amenorrhea, and dysfunctional uterine bleeding. We have got infertility due to anovulation. Okay, we have got signs of hyperandrogenism such as hirsutism, just a male facial pattern hair growth on the female body. We've got acne, okay, which is persistent beyond puberty, suggests a source of androgens. We've got androgenic alopecia, just male pattern hair loss. We've got metabolic markers such as the acanthis nigricans, just the velvet pigmentation, often in the armpits and in the neck, sometimes even in the thighs. Okay, so that's a marker of insulin resistance. We've got central obesity, okay, obesity with the thin limbs. Okay, just to, as we can see, all what we've talked about is here: the central obesity, there's acanthis nigricans, there's acne, there's alopecia, and there's hirsutism there. Okay, so with that being said, remember these patients with central obesity often have difficulties in sleeping, so they have got obstructive sleep apnea, which is common in obese patients. We need to ask that in our history. They've got visual clues of facial hirsutism, and also coarse facial hair, which is often present. Okay, so when we're doing our investigations for these patients, we need to go we need to start with our endocrine investigations, such as we need to also check for the elevated LH, okay, FSH, we need to check. So when we do the LH and FSH, you find that it's a 2-to-1 ratio, and there's elevated free testosterone due to the reduced sex hormone binding globin, and also high hyperinsulinemia. Okay, we need to check for that. We need to do our glucose test just to make sure. Okay, so the timing of the test, the blood test should be in the first week after the after menstruation has happened. Okay, so it has been good results have been shown after that time. Okay, so we also need to do our biochemical investigations such as elevated serum testosterone, LH and FSH. Okay, the DHERA. We also need to check for increased estrogen, okay, and estradiol, okay. We also need to check for low sex hormone binding globin. We need to check for low serum progesterone, okay, if they're having an ovulation. We also need to check for possible prolactinemia. Okay, we need to do a prolactin test. We get some blood just to exclude thyroid dysfunction. Okay, so we also need to do metabolic tests. Okay, under metabolic tests, we just talk about the insulin because hyperinsulinemia is common. We also need to do a lipid profile because hyperlipidemia is also common. Okay, so when it comes to the imaging, the gold standard imaging is an ultrasound. So you need to do a transvaginal ultrasound, which will show enlarged ovaries, okay, multiple small follicles, okay, subscapular, there's increased stroma there. Okay, we can also do a diagnostic laparoscopy if our setting allows us to do that. We can also do a bilateral polycystic, which is going to show bilateral polycystic ovaries if it's done well. So when you do the ultrasound, okay, when you do a biochemistry test, the testosterone result is mostly greater than 2.5 micro nanomoles per liter. Okay, so it's just elevated. When you do the ultrasound or a pelvic ultrasound, it's going to show enlarged ovaries, okay, showing stroma there with multiple small peripheral follicles, so neck-like in appearance, as you can see. So that those darkish small holes there are the follicles. So there are multiple follicles, so there should be at least 8 to 11, okay, or 8 to 12. Okay, so at least you can see that there are more than 8 here. Okay, they can also see a string of pearls there. Okay, so that's why we describe it. Okay, so you can also do a CT and MRI, but ultrasound is a gold standard imaging. Okay, so before we look at the management of these patients, we would like to look at the complications, the long-term complications of patients who are having polycystic ovarian disease if an intervention is not done early. So it's one of the common reasons for infertility. Okay, the other complication is diabetes mellitus and gestational diabetes due to insulin resistance and obesity. I'm for the view that PCOS often causes diabetes mellitus if it's not treated in due time. Okay, I don't just think you having PCOS, you're going to already have diabetes type 2, but I'm of the view that prolonged untreated PCOS can cause diabetes type 2 because of the chronic hyperinsulinemia. Okay, because your body is being exposed to that excess elevation of insulin resistance, so you might end up having or developing type 2 diabetes or gestational diabetes. So there's also increased risk of cardiovascular disease because of the hypertension, dyslipidemia, okay, low high density lipids, and metabolic syndrome. Also have increased the risk of transient ischemic attack, stroke, okay. Atherosclerotic risk factors addition such as polycythemia can contribute, endometrial hyperplasia and endometrial carcinoma, so this due to unopposed estrogen from the follicles. anovulation, okay, and obstructive sleep apnea. Because of that, obesity can contribute to the complications, and also right heart failure or copulmonale and hypertension. So these are some of the risk long-term complications of polycystic ovarian disease. Okay, so with that being said, this is also just so you know what we've already talked about, the metabolic presentations of polycystic ovarian disease. Okay, we've talked about the endometrial cancer and also the endometrial hyperplasia. We've talked about hyperinsulinemia. Okay, all these are been talked about already. Okay, so we go to the management. So in view of the management, you should understand that our goal is to reduce the metabolic risk, restore menstrual irregularities, treat hirsutism, the acne, and also induce ovulation if fertility is desired. So the first line goal is to advise the patient to for weight loss via diet or regular exercise. Even it's been shown to say moderate weight loss improves insulin sensitivity and may restore ovulation. Okay, so the medical management, we need to put these patients, if they are coming with menstrual irregularities, we need to put them on combined oral contraceptive pills. We need to provide, which are going to help with providing regular menses, increase the sex hormone binding globulin, which is going to reduce the free testosterone and also going to suppress ovarian androgen production. We also need to put them on cyclic progesterones if oral contraceptive pills are contraindicated. Though oral contraceptive pills have been shown to worsen insulin resistance in some patients, so the gold standard is just combined oral contraceptive pills unless contraindicated. Okay, with that being said, we also need to look at how the patient is presenting. If they have hirsutism and acne, we can put them on topical ointments such as um, we can put them on topical ointments. We can do a physical removal such as shaving, waxing, electrolysis, and laser removal. Okay. So the other topical ointments, we can put them creams such as eflornithine, which reduces facial hair growth via ornithine decarboxylase inhibition. We can also put them on anti-androgens such as cytoprotolone acetate and androgen, which is just an androgen receptor blocker, which reduces androgen synthesis. Okay. We also need to put them on spironolactone, which has been shown to have anti-androgenic effects at target tissues. Okay, so oral contraceptive pills also reduce hirsutism. So with that being said, pharmacologically, if they are coming with insulin resistance, you can put them at least on metformin 500 milligrams 3 times a day. Okay, which improves the insulin resistance, weight, the lipids, and also improves the menstrual function and aids in fertility in many patients. So if these patients desire for fertility, you can also induce fertility by using the first line, which is clomiphene citrate, to stimulate ovulation. If it's refractory or does not work as it's supposed to work, you can put them on exogenous gonadotrophins, okay, so which are reserved only for refractory cases when things don't go as planned. We can also give them combined oral contraceptive pills for those not desiring pregnancy. Okay, so we can also put them on newer progestin such as levonorgestrel, which can be an IUD or it can be in form of a pill. They help with menstrual regulation. We can also put them on neonastrate and medroxyprogesterone acetate. Okay. So the mechanism of how insulin helps with insulin resistance, just a recap, is insulin increases, metformin increases the insulin sensitivity, which reduces hepatic gluconeogenesis and lowers circulating insulin, okay, and also decreases ovarian androgen stimulation and improves the menstrual cycle, okay, and also aids in ovulation, okay. So with that being said, um, we have already talked about the anti-androgens such as cytoproteinuric acetate, spironolactone, which are used with contraception to avoid the teratogenic risk. So what do we mean by this? We mean to say that when you're giving patients drugs like clomiphene acetate, we need to add or maybe combined oral contraceptive, because they put the patient at risk of having teratogenic risk side effects. Because when they have a male child, you find that that male child is born with birth defects, and the male child is having feminine traits or presentations. That's why we need to put them on contraception. Okay. So with that being said, we can also put them on gonadotrophin releasing hormone antagonist, or the newer progestin therapy such as the levonorgestrel. We can also put them on surgical. We can also do surgical procedures such as a laser hair removal or electrolysis for hirsutism. You can also do a laparoscopic ovarian drilling and other surgical fertility interventions in selected um, situations in case of refractory infertility cases. Okay, just to consolidate on the infertility and ovulation induction, lifestyle modification and weight loss may restore ovulation. So before you go into pharmacological, you can advise for the weight loss and also lifestyle modifications. You can also put them on pharmacological induction via clomiphene citrate, okay, which is just an anti-estrogen for ovulation induction. If clomiphene citrate fails, you put them on a gonadotrophin therapy, okay, FSH or both combined FSH and LH, okay, or a metformin adjacent, okay. If all these things are refractory or they do not work well, you can put them on, you can do surgical option, you can do a laparoscopic ovarian diatemy, okay, drilling to destroy the multiple cystic areas if medical therapy fails. Okay, so just to summarize everything, the stepwise management is to cancel and initiate weight loss, okay, diet plus exercise to treat the menstrual irregularities, okay, with oral contraceptive pills or combined oral contraceptive pills, okay, or any progesterones or the newer progestins. We can use metformin for insulin resistance, okay, to improve ovulation if indicated. We can also improve induce ovulation via giving clomiphene citrate, okay, or any gonadotrophin therapies. We can put them on the patient on, such as the LH or FSH combined. We can address hirsutism with combined approaches, which can be cosmetics with eflornithine, or we can use topical or anti androgens, okay. So with that being said, we come to the end of the lecture and hope you've understood one or two things and it's been helpful. Thank you very much for listening and paying attention. We meet in the next session.